Well, good evening, everyone. We are just after 6 o'clock, so you're welcome to this week's, or it's a bi-weekly now, Wednesday evening webinar. And this evening we have a regional update from Cork and the HSE South-Southwest Hospitals Group. And I'm very grateful to Professor Paul Redmond, who has kindly put the programme together this evening. And he will introduce Mr. Zishan Razak, who is an endocrine surgery. And I think, Zazine, this is your second time contributing to our Wednesday evening webinar, so thank you very much. And we welcome Yasser Kaival, who's an emergency surgeon and general surgeon in Cork University Hospital and Bantry General Hospital. And I think, Yasser, there will be great interest in your talk as the evolution, I think, of emergency surgery as a discipline in its own right of general surgery, I think is very important, particularly when we have level 3 and level 2 hospitals that require a great range of expertise available for people who come into the emergency room. And then we welcome back Derrick Powers, who's a medical oncologist at Cork University and the Mercy Hospitals, who's going to give us an overview of cancer genetics in 2021. And I'm sure that will be an extraordinarily interesting update for us. Can I just ask, in view of the housekeeping needed, that if you're not speaking, please do turn off your camera and do mute your microphone to avoid getting feedback which can interfere. Please do use the chat function for any questions. And as we've got 3 quite different topics, do put your question in during the topic as it's being presented. And Paul Redmond will bring it up with our speakers at the end of each of the talks. Of course, if there's time, we will have a more general discussion at the end. So Paul, can I hand over to you, and thank you again for organising such an interesting evening for us.
Thank you, President. I'm having a little difficulty with the camera, but hopefully you can hear me. We here very much welcome the opportunity to give some updates on some of the things going on here in the South-Southwest group of hospitals. We ourselves are based in CUH, but the overall hospital group spans 6 public and 3 private hospitals. There are 3 public hospitals within the city, and then there's Mallow and Bantry, and of course we have Kerry University Hospital as well. The CUH would be the primary hospital here and is a very large tertiary referral centre, currently undergoing development for a new trauma tower and obviously offering the broad spectrum of cancer services as well. Given the different talks we have this evening, I won't pontificate for too long, but rather we'll go straight on to this evening's speakers, who will give slightly different talks, but I hope will give a flavour of some of the current issues that we address and some of the developments that are taking place here within the South-Southwest surgical community. So it gives me great pleasure, firstly this evening, to introduce Mr. Zishan Razak, who I've worked with for many years and who's a great friend and colleague. And Zishan is special lecturer and locum consultant surgeon here in the hospital with a special interest in endocrine surgery. And Zishan, we would welcome you to give us a little update on recent advances in endocrine surgery. Thank you.
Introduce you all.
Yeah.
Thank you so much. I'll just share my screen. I trust everyone can hear me and see my screen okay?
Zishan, it's a bit difficult to hear you, so maybe come closer to the microphone.
Sure, Prof. Thank you. Can you hear me now?
That's much better. Thank you.
Perfect. Thanks, Prof. So thank you, Professor Redmond, for the kind introduction, and thank you, Professor O'Connell, for inviting me for a second time to this prestigious Wednesday afternoon RCSI lectures series. So the timing of this presentation couldn't have been more perfect because I've just come back from the annual British Association of Endocrine and Thyroid Surgeons annual meeting in Leeds last week. It was my first face-to-face meeting since the pandemic has started, and I'll try to incorporate some of the updates in the thyroid and parathyroid endocrine surgery from that meeting into my talk today. So I've noticed 2 years in this for this talk, and this is the beautiful city of Cork, where myself and Professor Redmond, other speakers live and work in. So this is the agenda of the next 10 to 15 minutes. I'll briefly describe the magnificent 7 thyroid surgeons, then going briefly into surgical innovation and how I look at it. Then I'll briefly describe the recent advances in thyroid and parathyroid endocrine surgery, which is the main topic, and then a couple of slides in the bright future of endocrine surgery. So while we talk about the recent advances in endocrine surgery, we should not forget our past. About 170 years ago, in the mid-19th century, thyroid surgery was regarded as an act of horrid butchery. And in Europe, thyroid surgeons were called as foolhardy. Now, and after 100 years, in the mid-20th century, thyroid surgery was regarded as the most efficient and safest of all the operations. Now, how did that happen? Obviously, things didn't happen overnight. It took the blood and sweat and a lot of hard work of a lot of thyroid surgeons, but specifically these 7 surgeons, which I'm sure you've all heard of and read of. Among these are Cocker and Bill Roth, who are the fathers of endocrine surgery and thyroid surgery in Europe, and Mayo, who is regarded as the father of thyroid surgery in America. So by the hard work and a lot of efforts and blood and sweat of these thyroid surgeons, that made thyroid surgery not only possible, but safe and feasible in the years to come. So a few things about surgical innovation. So this is a nice read as a guide to good practice published in the English College. So whenever somebody wants to start a new surgical procedure in terms of surgical innovation, these are the steps that one has to go through. The idea starts from literature search and presenting that idea or a new procedure in the journal clubs. This is followed by listening to the experts on that topic by expert talks. Then the first hands-on experience comes from operating on animals in form of cadaveric labs. And once you get this through, it's very important to find a mentor or find a supervisor who would help you and supervise you in the first few procedures. Now, obviously, each procedure has its own learning curve, and the learning curve depends upon the type of procedure and the experience of the surgeon. Now, it's very important while a surgeon is going through a learning curve for a new procedure is to reassess the safety of that procedure for the patient, because eventually it's the patient outcome is the main outcome measure for all surgeons. But also look at the suitability and affordability of that procedure in the healthcare setting where one is working in. It's equally important that one goes through the learning curve and passes through that. It's very important to write that procedure and to teach and mentor that procedure for the younger generation of surgeons to come, so that that procedure becomes acceptable, and you train people on that. At the same time, it's also very important, and we've all taken the Hippocratic Oath, that first, please do no harm to the patient. And as a few people say, a fool with a tool is still a fool. So it's important that patient safety is kept in the center of all of that. I like this quote from Steve Jobs when he says that technology is nothing. It's the faith in people, which is more important than technology itself. And once you have this faith that people are good and smart, and if you give these people the exact tools, then they will do fantastic things with that. And I think surgical innovation is also true in this aspect. Now, going straight into my talk, I'll just touch a few recent advances in thyroid surgery, starting with the thermal ablation of thyroid nodules. Now, previously, as you know, surgery has been advocated for large, benign, and functional thyroid nodules. But now there's the option of thermal ablating them, and there are 2 options of thermal ablating the thyroid nodules. One is by radiofrequency ablation, and the other one is by laser ablation. This is a simple procedure done under local anesthetic ultrasound guidance. Once the nodules are injected, it takes about 6 months for the full effects as shown in the ultrasound here. There's a lot of evidence now in the literature, including this systematic review and meta-analysis published in 2019, showing 24 studies where above 1,000 patients had RFA and above 2,000 patients had laser ablation. And this cohort of 3,000 patients, they did very well, not in terms of thyroid volume reduction, but also there was marked improvement in their compression symptoms and their cosmetic outcomes. And more importantly, there were no adverse features. So this is an important tool. I know as surgeons we like to operate, but this is an important tool in hand for those younger cohort of patients who don't want surgery, who don't want scars, and who don't want surgical morbidity, to have an alternate option to ablate these functioning or non-functioning thyroid nodules as an alternative option. So this is something that has come in our hospital as well. We have a very experienced thyroid radiologist by the name of Dr. Barry, and she does a few thermal ablations and oncologic ablations for these nodules. This is the hot topic of discussion in the base meeting last week and everywhere else, which is why do we need molecular testing for genomic profiling of indeterminate thyroid nodules? For non-endocrine surgeons in the meeting today, I would just like to say that when we see a patient with thyroid nodule, the first line imaging is ultrasound and biopsy, which is FNAC, fine needle aspiration cytology. And then the FNAC is read in terms of the scoring system, which in UK is the Thai scoring system, and in Europe too, and in America is known as Bethesda scoring system. When they are Thai 1 or Thai 2, that is when they are benign. It's easy to manage them. They don't need surgery unless they are symptomatic. And when they are Thai 4 or Thai 5, they are cancerous, so they are also subject to surgery. But what happens when they are indeterminate? At the moment, the procedure of choice for indeterminate thyroid nodules is a diagnostic lobectomy. If you have one Thai 3F or if you have Thai 3A choice. However, it is important to note from this slide that the incidence of malignant histology after diagnostic lobectomy after these procedures is only 20 to 30%. So basically, in 7 to 80% of patients, you have done the surgery unnecessary, subjecting these patients to all the risks of thyroid surgery, including bleeding, scar, and nerve injury. And those 20 to 30 patients, 30% of patients who had cancer diagnosed, this is not definite surgery because they still need a completion thyroidectomy for completion. Hence, Thyroid has come into its space in 2014 in America. This is a thyroid genomic classifier gene testing. In 2014, when it started, it consisted of 20 genetic genes. And now in 2020, it has expanded itself to above 100 genes. And the main advantage of Thyroid is that it is done on basis of the FNAC, which is done at the time of initial diagnosis of thyroid nodules. And based on the Thyroid result, if it is negative, the incidence of cancer is only 3 to 4%. So rather than doing diagnostic lobectomies, you can observe these patients. But on the other spectrum of the results, if it is strongly positive with a high risk of genetic mutations, then rather than doing a diagnostic lobectomy, you can straight away go for a definite total thyroidectomy with lymph node dissection. Hence, using this Thyroid genetic testing, you reduce your false negative diagnostic lobectomies, hence reducing the incidence of a lot of morbidity with this surgery. In addition to Thyroid, Afirma and Thyroid Next have also been available since. The problem with this genomic profiling is twofold: the availability and the cost. Unfortunately, it's only available in America and it is slightly expensive. However, it is thought that with time, more and more endocrine and ENT surgeons will request these genomic profiling, and it will become more feasible and less and more cheaper. Another hot topic of discussion in the base meeting was the HOT trial, which stands for hemithyroidectomy or total thyroidectomy in low-risk thyroid cancers. Now, they were planning to start this trial in the UK at the end of 2020, but of course, COVID came in, and now they're hoping to start the trial by the end of 2021. So what thyroid surgeons think that total thyroidectomy for a low-risk thyroid cancer is probably an overkill, and hemithyroidectomy is more than sufficient. However, there isn't enough data to support that. That's why this trial, hopefully, with this result favoring hemithyroidectomy group, will change the practice. I have put the names of the investigators and co-investigators on the site if some center in Ireland want to be a part of this randomized controlled trial. Now, going straight into the recent advances in parathyroid surgery, after which I'll finish my talk. The main topic of contention in parathyroid surgery is always which approach is better, is the unilateral, targeted, or minimally invasive approach, or the bilateral neck exploration approach. Of course, for unilateral approach, you need imaging guidance and localization pre-op, which is can be in form of ultrasound, system AB scan, or CT scan. And also you need the intraoperative adjuncts like the intraoperative PT HSAs, the gamma probes, and frozen sections. On the other hand, four-gland exploration is indicated in a few conditions where you have four-gland hyperplasia and where you can't do a focus surgery. Examples are patients with MEN1 syndrome or patients with four-gland disease, as it happens in some cases of primary and in all cases of secondary and tertiary or renal hyperparathyroidism. What are the advantages of minimally invasive surgery as we move from bilateral neck exploration to minimally invasive surgery over the last decade or so? Well, it's a smaller incision. It's a quick operation, takes about 20-25 minutes on average, because you're not doing a lot of dissection. You're only excising the parathyroid gland, which is picked up on imaging. There's less hematoma, there's less nerve injury, the recovery is quick, and most of these patients, they go home on the same day. Now, the question remains, is localization necessary? Well, in 1986, in this paper, the answer came in as, in the opinion of the authors, the only localization study indicated in these patients is to localize an experienced parathyroid surgeon. And that is very, very true, as there is no shortcut to experience. However, even a very experienced parathyroid surgeon will sometimes fail in a challenging parathyroid surgery. Hence, the need for pre-operative parathyroid localization with these scans like an ultrasound, system EB scans, and the 3D SPECT CTs. Now, does imaging improve outcomes? Now, this is the data from a single American hospital saying that when imaging was utilized pre-operatively in these patients, the operation was finished unilaterally in 2/3 of the patients. But when imaging was not utilized pre-operatively, only 13% of patients had unilateral operation. Hence, shows the importance of pre-operative imaging. Now, why is pre-operative imaging exciting? Well, this is the SPECT/system EB scan that we've done on one of our patients. And look, it is showing a glowing right upper parathyroid adenoma, which was excised very quickly and the patient went home the same day. However, the sensitivity of these scans is not 100%. As you can see, this poor system EB scan, which is not showing any localization, and hence you have to do a bilateral neck exploration. But why is preoperative imaging important? It is important in patients like this, which have an ectopic parathyroid adenoma in the anterior mediastinum. And doing a neck approach in these cases, patients would be wrong, as you can't take it out from the neck. And if you have preoperative imaging, that will guide you to do a sternotomy and taking out this adenoma from the thorax. Now, these are our minimally invasive radiothyroidectomy incisions, which are pretty small, 3 to 4 centimeter. We normally do a Cochrane incision in the midline, although some parathyroid surgeons, they make a focal incision or the specific parathyroid, like in the left upper parathyroid in this instance. Now, we've done a little audit in our department that we presented in FRAIRS and SRS last year about the intraoperative agents that we use. So very briefly, we use 3 intraoperative agents: the intraoperative PTH assay, done preoperatively and done 5 minutes after excision of the parathyroid adenoma, which we expect a 50% drop. Then we do a 20% rule with gamma probe, where the activity of the parathyroid adenoma is 20% or more of the background to be a successful surgery, and all these adenomas, they go to frozen section. In our study, we had 45 patients, mainly females with a mean age of 62. 20% rule was positive in 43 patients who had the parathyroid adenoma excised. However, in 2 patients who actually had thyroid tissue excised, it was negative, hence sensitivity of close to 100%. PTH did drop in 41 patients, however, did not drop in 4 patients. Now, 2 of these patients had thyroid nodules, but 2 patients with successful parathyroid adenoma excised did not have a drop in PTH. Hence, the sensitivity was close to 95%. But the frozen section sensitivity was 100%. Hence, we concluded based on this data that using the 3 agents together, as we do in our practice routinely, would reduce the incidence of persistent and recurrent disease and surgery to a minimum. Now, in the last couple of slides, in the interest of time, there are a few latest innovations for parathyroid localization, which has come now in the last few years. A couple of them are probe-based, like the parathyroid eye or PTI, and the NERAF, and one of them is imaging-based, which is the ICG autofluorescence. So parathyroid eye is a handheld fiber optic probe with a foot pedal. And once you take it close to an abnormal parathyroid adenoma, it will beep, and it will give the endocrine surgeon the idea that they are close to a parathyroid adenoma, especially if it is an ectopic location and you can't see it. More exciting than that is the NERAF technology, which stands for near infrared autofluorescence imaging. Unlike ICG, you don't have to inject these patients, and you can see an abnormal parathyroid adenoma lights up very nicely using NERAF. The major advantage of NERAF is you can distinguish a healthy from a diseased parathyroid gland, so you don't take out a healthy gland. However, NERAF has its problems, its false positivity rates, its false negativity rates, and more importantly, with NERAF, you cannot assess the viability of parathyroids in the live setting. However, with ICG fluorescence angiography, which we've recently used in CUH on a couple of patients, you can not only check the viability of the parathyroid as you go along, but you're also able to save the parathyroid with their blood supply. So with ICG, you have 3 scores ranging from 0 to 2. 2 is the score when you have a white glowing parathyroid saved along with blood supply. 1 is when you have a medium vascularity parathyroid gland, which looks gray on ICG, and then black is when the parathyroid is saved with no blood supply. And we all aim to have a score of 2. There's a lot of literature recently, including this RCT from the Swiss group, saying that using ICG angiography obviates the need for post-operative measurements of calcium and PTH, and no calcium supplementation is required, even if you leave one perfused parathyroid gland using ICG. Looking into future, they're trying to implement some goggles to look at the parathyroids and tissue projection, so the endocrine surgeon doesn't have to look at the screens. And they're also talking about laser speckle contrast imaging. So the future for parathyroid surgery looks very bright. At the end, I would like to conclude by saying that, there's no shortcut to experience. Last week in Leeds, I met Mr. Coombs, who's a very famous parathyroid surgeon. So he gave me 3 pearls of wisdom. He said to me, son, even the best surgeon will fail sometime in parathyroid surgery, so don't worry. More importantly, because parathyroid is a benign pathology, please do not do any harm to the patients. Do not remove normal parathyroid that will make the patient hypocalcemic for life. And in any instance, do not injure the nerve. And last but not the least, if you can't find an abnormal parathyroid, look at abnormal anatomy, look at the ectopic size, and always keep the embryology in mind. So I would like to end my talk by sharing quotation from Dr. Atul Gawande, the American endocrine surgeon. And thank you very much for the invitation again, Professor Redmond and Professor O'Connell. If any questions, I would like to answer them at the end. Thank you so much.
Thank you very much, Zishan, for that endocrine tour de force. And we didn't even get around to the adrenal glands there, but we learned a lot from those 2 talks. And I know you've had the benefit of attending the British Association of Endocrine and Thyroid Surgeons last weekend and updating us on what went on there, which is really, really good. One question that I think is being asked before we move on to the next speaker, and we'll stick with this, is some people will say that endocrine physicians are very slow to refer patients for parathyroid disease. Do you ever think that we'll get unanimity about criteria for surgical excision of these lesions? As you know, many of these patients are diagnosed or poorly diagnosed and left with the disease on the basis that it's not a bad disease as such.
Thank you, Professor, for your question. So, that is as you know, a lot of parathyroid disease is not diagnosed because a lot of these patients are asymptomatic and it's only picked up incidentally on routine bloods. And when patients do have symptoms, they often present at a very late stage. So there's no screening at the moment, although we are trying our best to implement screening here in Cork locally. But I think there needs to be education, not only to the endocrine physicians, but also to the GPs and all the different doctors working in different specialties to pick up these patients when they're asymptomatic based on their bloods, and when they have symptoms, refer them to the appropriate parathyroid surgeon so they can be cured by a simple operation, which is simple in most of the cases and results in a very good outcome for these patients.
Okay, I think, President, did you want to say something?
Just to say, I thought that was a fascinating presentation and also very, very helpful to have a presentation from somebody who's just attended a state-of-the-art meeting to bring back to us the most recent innovations. So thank you for that, and I won't prolong discussion because we've got 2 more presentations. Thank you.
Thank you, President. We will move along now to our next speaker, and it gives me great pleasure to introduce Mr. Yasser Kayal, who is a lead consultant in emergency acute surgery here at CUH and consultant in gastrointestinal surgery. I think it's fair to say that Yasser has played no small part in establishing the emergency surgery service here in the hospital, which is an extremely large service, and there are now 4 permanently appointed surgeons as well as 2 locums within his department. He has done a significant amount of work to ensure that he has a dedicated emergency theatre and a surgical assessment unit. And Yasser, we look forward to your presentation. Thank you.
Thank you very much, Prof. Redmond, for the kind invitation. Thank you, Mr. President, for having me tonight. I'll try to convince you, as I was asked by Prof. Redmond, that emergency surgery is an evolving specialty. Next slide, please. I'll start with a brief history about the topic. So next, please. This actually is the oldest known medical manuscript, and it is a trauma textbook. It was written by the ancient Egyptians about 5,000 years ago. It was named after Edwin Smith, who bought it in the 19th century, and practically it's a manual of military surgery that describes 48 cases of injury, fractures in a logical and systematic treatment modalities of traumatic injury. Next, please. Mr. William Halstead is a well-known surgeon, and he did say again in the 19th century about the topic of emergency surgery that every important hospital should have on its resident staff of surgeons at least one surgeon who is well and able to deal with any emergency that may arise. Next slide, please. We are all familiar with the golden hour concept, and this was brought by Dr. Goodfellow from the United States, who says that if you don't operate within the first hour, you have probably lost the patient. Next, please. Now, the current situation in the surgical community is that everybody is looking into subspecialization, and in the recent years, those subspecialties kept on expanding, like the colorectal, the upper GI, the thoracic, the bariatric, endocrine, minimally invasive, HPV, and the list goes on and on. Next, please. However, there is globally current issues with emergency surgery, and that includes few points that I will touch upon. Most of the surgeons nowadays are more interested in their own field, so they're narrowing their practice. There's a problem with the current trainees that they want to pursue subspecialty early in their career. The specialists are no longer feel qualified or confident to perform emergency surgery procedures, and some specialists are not willing to do emergency calls because of the issues with the lifestyles. And specialists may take longer to perform a surgical procedure that they no longer routinely perform. And all these points raise the concern about patient safety. Next slide, please. In this slide, it's from the United States, and it summarizes that the emergency general surgery patients are a different group of patients because they're more likely to die, 8 times more likely to die. They have 50% chances of having post-operative complications. They have 14% readmission rate, and 20% of them will have a discontinuity of their care. Next slide, please. Now, I'll start with the global perspective, and this paper actually is a systematic review that was published in the World Journal of Surgery in last year only, in 2020. And those authors, they look at 62 articles from 13 different countries to look at the models of acute care surgery in those different countries. Unfortunately, they mentioned that most European countries doesn't recognize acute care surgery as a specialty yet. However, they found out that the earliest studies from this group was coming from the US and the Australia. Next slide, please. They did conclude that there is a variability in the implementation, and most of those studies was carried out in high-income countries. The American model incorporates surgical critical care with acute care surgery and with trauma and emergency surgery, and they suggested that a global consensus should be reached in order to develop this field of surgery. Next slide, please. This is from the same study, and that the highlighted areas are the countries that was looked at. Next slide, please. And if you look at this slide and the next slide, you will notice that most of these papers came from Australia, Canada, New Zealand, USA, and UK, where they were the early adopters of the model of emergency surgery. Next slide, please. Next, please. So there was a paradigm shift, and things started as usual from the United States of America with the concept of acute care surgery. Now, the acute care surgery concept in America includes 3 components. The first one is the trauma surgeon, second one is emergency general surgeon, and the third one is surgical critical care. Next, please. So that what pushes the American College of Surgeons, then the AAST to sit down and decide how they're going to proceed this, and they suggested that trauma and general surgery should together work to create a specialist that can manage both, and the graduated from this training is responsible for managing acute surgical patients and providing surgical critical care. Next, please. So they came up with recommendations that the training needs to be 2 years fellowship. They need the trainee should spend 9 to 12 months in surgical critical care and 12 to 15 months in trauma and advanced surgery. Next, please. The project started in 2007 with surveying the sites and putting on the fellowship curriculum, and they conducted the interviews, and the actual training started, the first fellowship started in July 2008. Next, please. Currently, there are 14 centers in the United States of America that provide a full accredited trauma and acute care surgery fellowships. Next, please. Now, this study comes from Australia, and it looked at the models of care for emergency general surgery in the country. Now, out of the 120 hospitals eligible, only 119 participated, and the authors found out that 54% of those hospitals have utilized a hybrid model. They've noticed that the acute surgical units implementation was more common among the largest hospitals with more beds, more surgical pool, and with trauma services. And they did conclude that it's a good service and it's dependent on the size of the hospital. Next slide, please. And you can notice from this slide that from 2004 to 2019, there was a sustainable increase of the number of acute surgical units and hybrid units in the Australian hospitals. Next, please. This is another paper from Spain, and they were also talking about the same concept, the acute care surgery model in the world, and how they're thinking of developing this in Spain. And the authors came with the term that's called TESU or TISU, which is trauma and emergency surgery units, and that the dedication of trauma and emergency surgery will lead to improved clinical care outcomes. And they recommended that every hospital and every surgical department should include a TISU unit within them to improve patients' outcomes and to look after the emergency surgery patients. Next slide, please. Our neighbors in the UK in 2017 also published this paper. They looked at the general surgery consultant as the frontline keeper of the emergency surgery. They compared 5 months before and after the implementation of a surgical triage unit. They call it the STU. And they found out that after the implementation of this service, there was 279 more patients discharged on the same day. There was a reduced in the length of stay. There was reduction in the emergency laparotomy in hospital mortality from 11 to 10%. And they recommended that this model of care should be implemented more in different hospitals. Next, please. This is a very interesting article I found out when I was preparing for this presentation. And again, it's coming from the UK. The authors of this, they look at the all consultant surgeon posts advertised in the British Medical Journal between January 2009 and 2014, and they divided into two-year bands. They looked at 2009 to 2011 and 2012 to 2014, and they found out actually that the number of emergency general surgery advertisements increased significantly in the last 2 years of the study. And this data demonstrated that there is an increased demand on the emergency general surgeons in UK. And to meet that demand, they were suggesting that there should be a change in the curriculum and in the surgical training for the residents, and the examination should be revised to meet that demand. Next, please. That's the conclusion. So next, please. Now, the European Board of Surgery, and that was a recent introduction of the emergency surgery as a specialty in 2018, the committee, they decided to come with the fellowship. Next slide, please. With the fellowship in the emergency surgery exam, which recognizes the candidate as a qualified emergency surgeon. Now it's open to all surgical trainees who can convince the eligibility committee that he has the ability and the credential to be named as a fellow of the European Board of Emergency Surgery. Next slide, please. So as I maybe convinced you, acute care surgery is still evolving, but it's not going anywhere. It's here to stay. But where are we going? Next, please. This article from the United States, who are leaders in the field, they did mention that since the introduction of the emergency general surgery in 2000, things have improved, but to continue in improvement, they suggested that there should be some steps taken to improve the service, and that's the creation of a data registry for emergency general surgery patients, and to report on the outcomes and complications, and to implement a quality improvement projects. Next slide, please. Another paper in 2019, again from the United States of America. They were trying to develop an architecture for optimal outcomes, and the authors suggested the following points. Number one is to standardize EGS definition. Number two, to get severity assessment tools and to use them for risk-adjusted outcomes. And again, they were suggesting development of a data registry for emergency general surgery, and to create guidelines and care bundles to standardize emergency general surgery across the United States of America. Next slide, please. I think most of you are familiar with this document. It was published in 2015 from the UK. I mean, from the American Association of Coloproctology, the Association of the Upper GI Surgeons, and the ASGBI in UK. And it's a 5 or 6 pages document that talks about key recommendations in the future of emergency general surgery and how it should be implemented worldwide. Next, please. So this slide summarizes the future of emergency general surgery in collecting data, creating registries, and improving outcomes for the emergency surgery patients. Next slide, please. Now back to our country, back to Ireland. This slide shows the model of care document that was published by the National Clinical Program of Surgery in 2013. And it's actually a very detailed and well-written document talking about the model of care for acute surgery and how it should be implemented, to be separated from the elective, to be delivered by a consultant, and to be aligned with other acute programs like acute medicine, acute pediatrics, and the likes. And it gives recommendations about dedicated resources in terms of surgical assessment units, theater access, looking at special issues like pediatrics and trauma. Next, please. And again, in the same document, they did show that in Ireland, and that's our own figures, the NCPS figures, 62% of all surgical admissions are acute. They either have a procedure or no procedure. So about 2/3 of patients is acute, and they need somebody to look after them. Next slide, please. During preparing this presentation, I came across this very interesting article in the Irish Medical Times from Prof. Oscar Traynor about the new curriculum for the surgical trainees that will be implemented this year, and that will include general surgery and emergency surgery as a special interest, and that will have a great impact on the future trainees to produce emergency general surgeons for the country that can work in Model 3 hospitals. Next slide. Now I'll walk you through our hospital. So what we've been doing and the model of care for emergency surgery that we started. Next slide, please. To start with the problem now, there are a few issues recently in COH that led to the development of the service. Because as you know, currently, emergency general surgery in Cork is taking place in 2 centers, in Cork University Hospital and Mercy University Hospital. Because of the recent reconfiguration of services, about 42,000 of emergency presentations has been redirected to our hospitals after the closures of the emergency department in Pantry, Mallow, and South Infirmary Hospital. Recently, the vascular and breast surgeons, they came off the general surgery rota. The NCBS data showed a double in presentations of the emergency surgical procedures from 562 in 2008 to almost 1,000 in 2015. Next slide, please. So the program started in the 1st of May 2017, and when we started, there was 2 dedicated emergency surgeons recruited for the post. Along with them, there was 2 registrars, 3 SHOs, 2 nurses for the surgical assessment unit, and 1 secretary. Currently, we're 5 consultants, 3 registrars, 2 SHOs. We have 2 interns on the team, and recently we're joined by 2 medical students that are attached to the unit. Every month we get 2 from the UCC. The nurses are there and 1 secretary is there. Next slide, please. The working schedule for us is that we have 2 shifts. We have the day surgeon and we have the night surgeons. Now, the day surgeon is one of the 5 emergency surgeons, and he's on call every day from 8 to 5. And then the night surgeon is the pool of surgeons, which are currently 10 surgeons, so we do 1 in 10. And that starts at 5 and finish at 8 in the morning. There is 2 handovers during the day. There is the morning handover where we take over patients from the night before, and there is the evening handover where we hand over any cases that require follow-up or surgery to the night surgeon. During the day, we cover ED, SAU, consults, theaters, everything that needs to be done on that day. Next slide, please. In our first 6 months of activity, because this was started as a pilot project and we have to show efficiency, so we did show the administration that we have a 6% reduction in appendectomies average length of stay. We have a 17% decrease in appendectomy readmission rates. We have increased the emergency laparoscopy cholecystectomy by 300% from before we start. We have improved the length of stay readmission rates for major colonic resection, a decrease in average length of stay for hernias, for small bowel resection, and readmission rates were the same, with an overall decrease in general surgical average length of stay of 17%. Next, please. We did also show an improvement in the emergency theater activity. Sorry, the numbers are not showing here, but we have a 19% increase in the theater 3 utilization. We have a 13% reduction in interval minutes and 9% reduction in the turnaround time. Next slide, please. Now, our surgical assessment unit was officially opened in November 2017. We started with six bays and 2 nurses, dedicated consultant, registrar, and SHO to cover the unit, and we managed to get the NCBS accreditation in June 2019. Next, please. Next, please. A few snapshots from the NIQUIS data. That's looking at the year 2017 and 2018, and there was around 2,000 discharges. Next slide, please. The next slide shows the demographics of those patients in details, but what I would like to bring to your attention is that our mortality rate for that year was only 1.5%. Next slide, please. Now, our statistics from the SAU for the first year, the total number of patients we saw in a year was almost 1,000. We admitted almost 80% of them, and we discharged 20%. So we saved on the admissions to the hospital. Next slide, please. Along the program, we have few quality improvement projects. We started with patient education materials about the most common emergency surgical presentations that we're giving to patients. We are running patient satisfaction surveys in the surgical assessment unit. We are working with different departments with our colleagues to develop clinical care pathways. We have cooperation from the maternity hospital, pediatrics department, radiology, and recently we started a combined geriatric and emergency surgery program. Next slide, please. In terms of training, we participated in this very interesting post-CSCST trauma fellowship that we developed recently with the help of the emergency department, and we successfully started our first fellow in July 2021, and only last week we got approval for a second fellow. Next slide, please. In terms of research and publication, we have participated in both national and international meetings, and the next few slides will show you what we've done. This paper is talking about an improvement in acute appendicitis presentations. Next slide, please. Another publication about the hot gallbladder program, which we implemented in Cork University Hospital since 2017. Next slide, please. Next slide, please. We presented a paper in Liverpool in the ASGBI 2018 about what we're doing and the model of care in CUH. Next slide, please.
Yeah, Yasser, could you try and finish up soon, please?
Okay, all right. So next slide, please. This is what we've been doing in terms of research and publication. Next slide, please. Next slide, please. So, next slide, please. Next. So to conclude, emergency surgery improve patients' outcomes. It's a consultant-led. It shows greater patient satisfaction. It improves patient flow. It reduces morbidity, mortality, and reduces length of stay and cost. And it's here to stay. Thank you very much, Prof. And sorry for the overrun.
No, I think thank you very much, Yasser, and the amount of data that you produced there is clearly demonstrative of your enthusiasm for what you have been driving and achieving here. So thank you very much. In the interest of time, I think we'll move along and see how we're doing at the end. There are lots of questions, Yasser, and maybe you'll end up having to take some of them a little bit later.
Yeah.
I'd like to move along to our final speaker this evening because I'm really keen to try and keep to time. I'm delighted to welcome Dr. Derrick Powers. Derrick is an RCSI graduate who is a consultant in medical oncology, both in our sister hospital here in the Mercy University Hospital, as well as here in CUH. He has a number of interests, but specifically he is interested in genetics and cancer, and he acts as a lead nationally and internationally for many of our melanoma clinical trials and protocols. So Derrick, you're very welcome.
Thank you, Paul. Thank you, Professor Redmond, for the opportunity to speak, and thanks to Professor O'Connell as well. Can everybody hear me okay? You can hear me, Paul?
Yes.
Great, okay. So I've been asked to give a talk on the marriage, if you like, between modern cancer genetics and surgery. So by way of setting the scene, just 1 second there, my slides aren't moving. By way of setting the scene, these two books are fantastic reading for those of you online with some time. The Emperor of All Maladies won the Pulitzer Prize, and this is a great journey on how cancer was first discovered and how surgery developed, oncology developed, radiation developed, etc. Really fascinating read, and probably relevant to this talk is The Gene by the same author, who's a doctor, on the genesis, if you like, of the gene. So to set the scene, where I work in the Southwestern Hospital Group, you can see the shaded purple area here. This is a very high incidence area in the country for cancer, significantly higher than most other parts of Ireland. Why this is, I don't know. We're in the middle of a cancer epidemic, in my view. This is NCCP data showing the really exponential rise predicted for cancer from now 15, 20 years hence. And the Irish Cancer Society have many publications on this showing the rather dramatic increase in cancer that we can all expect as clinicians over the next 20, 30 years. So to get all this together, we have a National Cancer Control Programme. And in my part of the country, CUH is the Regional Cancer Centre. And as Professor Redmond alluded to, links in with the Mercy Hospital where I work, the South Infirmary Hospital and University Hospital Kerry. And then we have the overriding governance with the University College Cork. So in my part of the country, relevant to all the surgeons, every surgical specialty is represented here in Cork in the hospitals that I've mentioned. So this puts me in a very good position where I can see many different cancers and get a chance to specialise in cancers where surgical specialists are on site dealing with the cancers. So critical take-home message from this talk is that if we can organise cancer, we can improve its outcome a lot. So cancer, of course, is a multimodality management. The best treatment for cancer is prevention, 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 and then surgery, local therapies, and systemic therapies. So we're all involved in multidisciplinary teams. I put down a multidisciplinary team here for colorectal cancer, and the same applies to many other solid tumour cancers that I have the privilege of being involved in. So this is a statement that I strongly believe is true. Cancer is a surgical disease. The most important intervention in most cancers is surgery. And I don't need to tell many of our listeners here that surgery has advanced considerably over many years, from open operations to robotic operations. And I know there's a lot of debate about what's the best oncologic outcome from these approaches, but suffices to say, surgical technique is improving exponentially, and as a result, cancer outcomes are improving. Here's a very poignant graph looking at resectability, or initially unresectable colorectal liver metastasis. And remarkably, if you can resect colorectal liver metastasis, remarkably, there is a possibility of cure. Without surgery, the median survival historically of metastatic colon cancer historically is about a year. Modern systemic treatments can bring this up to 2.5 years, but surgery gives a realistic possibility of cure. And you can see over on the left-hand side of the screen here, with liver resection versus without liver resection, there's clear separation of the survival curves. So surgery is the critical intervention, to such an extent in colon cancer that we almost need a new staging system of resectable metastatic disease versus unresectable metastatic disease. But cancer, of course, is a very clever disease. And as this graph shows here, surgery is not the only answer. It is the critical intervention, as I mentioned earlier, but you can see here the KM curves for stage 3 resected melanoma. Clearly a huge difference from 3A to 3B to 3C, 3D, etc. And you can see that the outcomes are very poor, even with surgery, for resectable melanoma. And why is this? Well, this is because cancer is genetic. It's a clever disease. Cancer arises from gene mutations that we acquire over time, or even are born with. And cells cycle through this cell cycle. And at various points in the cell cycle, we can try and discover Achilles heels and synthesize drugs to attack the cancer. There are hallmarks of cancer. Many of us would be familiar with the Weinberg graph here showing the 6 hallmarks of cancer. I won't read them all out, but suffices to say phenomena like angiogenesis, apoptosis, etc. are all hallmarks of cancer, underlining why surgery alone in a lot of diseases won't be the answer. Cancer is very clever. It can regulate networks. It can evolve. It can avoid immune destruction, which is very topical, and I'll talk about this later. It can lead to instability of genes, and it can return in micrometastasis despite the fact that it's been resected. So colon cancer, for example, isn't just one disease, as many solid tumour cancers, if not all, are not just one disease. I think historically that's why colon cancer did very badly and melanoma did very badly, because it was viewed as one disease, but nothing could be further from the truth. The genetic changes in colon cancer are bewildering, almost resembling the Tokyo subway. And as a result, all the new molecular classifications have led to new treatments and I would argue should lead to different surgical approaches, underlining the topic of my talk about marrying modern cancer genetics with surgery. So for example, in the colon, the right side of the colon has a different embryologic origin to the left, and there are very distinct biologic changes in the right colon cancer versus the left, and therefore outcomes are different in right versus left. And I think it's very important that surgeons and medical oncologists know this. Colorectal cancers differ considerably at the molecular level by location I've just alluded to, and even by gender. And to go back to the metastatic colorectal cancer liver situation that I spoke about earlier, if there is a mutation called BRAF in colon cancer, which is present only in about 6 or 7% of colon cancers, this very large retrospective data from Memorial Sloan Kettering, looking at almost 2,000 patients who had metastasectomy with metastatic colon cancer and who had BRAF status. And here is the difference. BRAF wild-type disease versus mutated disease. Clearly, the outcomes are much worse for BRAF mutated disease. And these authors pose the question, should surgeons be removing liver metastasis in BRAF mutated disease because the outcomes are so poor? So clearly very hypothesis generating, and another example of how cancer genetics has a real impact on surgery. So genetics aren't just somatic in the tumour, they're also in the germline, and I'll talk about this later. So one of the seminal scientific events in our lifetimes is the sequencing of the cancer genome and the human genome. And this can really impact on the management of cancer. And cancer can be subdivided into this: all cancer is genetic, about 20-25% run in families, and about 5, maybe 10% are hereditary. And this can really impact on the surgical management of the disease. So there's a huge evolving role for genetics in cancer care, and these are very realistic expectations in our lifetime. They're already happening. We can diagnose cancer better because of genetics. We can prognosticate better. We have much better therapies now. We can risk assess better. We can improve risk management. And I would argue the surgical approach may change considerably depending on the genetics. So in my world, we have a lot of targeted therapies now. Here's some of the targets that have been exploited. And it's really quite bewildering how quickly drugs can go from a powder in the laboratory to a tablet or a capsule or an injection in the marketplace. So a great example of this years ago was the drug imatinib, which took a long time to come to clinical trials and then was very quickly approved for the treatment of chronic myeloid leukemia and GIST, and it can cure those diseases. And we've many other drugs now, a bewildering array of drugs that I won't go into in great detail. But this drug, Gleevec, made the front of Time magazine in the early 2000s. And this really is a magic bullet, which is the holy grail of targeted therapy. And speaking of the magic bullet name, this is a book, great book to read, of the former CEO of the company Novartis, which nearly went bankrupt, bringing the drug imatinib to the marketplace to treat a relatively rare disease, about 6,000-7,000 cases a year in North America, chronic myeloid leukemia, but can cure that disease and can also cure GIST tumours. So here's one of the first PET scans ever published showing a very hot, active GIST tumour in the pelvis, and it can be rendered cold and potentially operable by this drug imatinib, which acts on the KIT oncofusion protein. And the sequencing of this is well known. There are good exon mutations to have in the intracellular domain, and there are poor exon mutations to have. So the surgical approach and the outcome from these tumours is really dictated on by the genetic mutations. You can predict risk of recurrence. You can predict response to imatinib purely based on the genetics. So this is a great example of how a disease is completely changed by genetics. And here's some scans of a completely unresectable rectal GIST abutting critical structures and how it can be cytoreduced by imatinib and to make it resectable. So here is in melanoma. We now sequence melanomas regularly using next generation sequencing, and a very common driver mutation seen in many cutaneous melanomas, about 30-40%, is BRAF. And we've exploited that now with targeted agents looking at attacking BRAF and further down MEK. genes. And there are many New England papers and other high-profile journals showing really amazing outcomes with BRAF and MEK inhibition for metastatic melanoma. Again, another example of a PET scan going from hot to cold because of these drugs. And in the right patient, which is always the case, even in surgery, in the right patient, the outcomes can be quite spectacular with these drugs. Here's 71% 5-year survival in metastatic melanoma that has a complete response to BRAF and MEK. And even the poor intermediate responders with very advanced disease can be doing well at 5 years. In breast cancer too, we have genetic signatures now through microarray technologies that many of you may be familiar with. And in these heat maps here, you can look at different genes that are switched on and switched off, and you can predict how cancers are going to behave. Do they have a good signature? Do they have a poor signature in terms of outcome? And breast cancer, for those breast cancer surgeons dialing in here, is not just one disease. It's a variety of different diseases that can behave in a variety of different ways. And we now have genetic testing, somatic genetic testing called Oncotype, that can predict the risk of recurrence of tumours over time for specific hormonal subtypes that are node negative. So we do this routinely now, and you can stratify disease based on this oncotype. So this is another example of how genetics have changed the realm of cancer, in that case breast cancer. The other big development in my world that's very relevant for surgery is the development of the human immune system, which potentially could be the ultimate anti-cancer therapy. So many of you may be familiar with how our immune system, specifically T cells here, interact with the tumour antigens on the antigen-presenting cells, and all of this here is an inherent brake. But if you put a brake on the brake with monoclonal antibodies, you can stimulate the immune system. And this has proven to be a very, very effective strategy of treating many solid tumour cancers and indeed some liquid tumours. And it seems to correlate with the mutational burden or the antigenicity of cancer. And it's no fluke that melanoma and lung cancer and bladder cancer are near the top of the list here. And these are the cancers that have shown the most efficacy with these new checkpoint inhibitors. So again, the data has come out thick and fast. Here is really quite amazing evidence of giving ipilimumab, a checkpoint inhibitor, and nivolumab together for metastatic melanoma. Here's 5-year survival of 52%, published in the New England a year or two ago. And this pivotal trial that we were very involved in here in Cork has just recently reported 6.5-year survival, and 49% of patients with stage 4 melanoma, unresectable, are doing well at 6.5 years. And there's been such a fever pitch with all of this in recent times that the Nobel Prize was awarded to these two people here in recognition of their efforts. And these people have really become rock stars in the immune world and in the cancer world. So we've moved melanoma with these checkpoint inhibitors right the way up with checkpoint blockade and other complementary treatments. So immuno-oncology is really the hot topic in medical oncology systemic treatments in modern times. So what's very relevant to surgery is the neoadjuvant approach. So I'm a big fan of this. There is a big precedent for neoadjuvant systemic therapy in cancers. And many of you online there, I'm sure, will know that many of these diseases now are routinely treated with neoadjuvant treatment prior to the definitive intervention, which is surgery. And we really need to make huge progress in this, especially in badly behaving cancers like pancreas cancer. So adjuvant is treatment that's given after the surgery, neoadjuvant obviously before. And with neoadjuvant, the powerful thing is here, you will know the pathologic status of the disease after the treatment, and this invariably correlates with outcome. So here's a pooled analysis of stage 3 resectable melanoma that was treated with neoadjuvant immunotherapy or targeted therapy, and you can see based on these numbers, which admittedly are small, this is now published in Nature Medicine this year, but admittedly small numbers, but it shows that if you have a pathologic complete response, which is up to 52% of patients, no patient has had recurrence of disease 2 years out, and this has just been extended to 3 years in the updated publication. Not as good with the targeted therapy. So this to me is very provocative and very hypothesis generating for the role of neoadjuvant treatment. But of course not everybody benefits, and this is where genetics comes in. We can now look at an interferon gamma signature and a mutational load in melanoma, and we can correlate that with the likelihood of getting a pathologic complete response. And you can see there, specific signatures will not get a response and specific signatures will. So we can potentially know this beforehand. And this leads to the whole area of metastatic disease. Myself and Professor Redmond and others have shared many cases where you can get immune escape and an oligometastasis can grow, and surgical resection of an oligometastasis in the era of immunotherapy and indeed targeted therapy can confer a big advantage to the patient. And we've seen many examples of this, and the literature is now awash with papers like this showing the role of surgery in advanced disease. So back to this pie chart again. What about germline genetic services in Ireland? This is a slide from 2019 and it's really quite depressing. So for surgeons and oncologists referring to cancer genetics, germline services were really very, very underserved in Ireland with respect to this area. You can see these very small numbers there for the whole country. And there is not much of an on-site service outside of Dublin, as far as I can see. And there's been moves afoot to try and address this. And these are data from St. James's Hospital in Dublin showing cancer genetics outpatients obviously are going up and up as our understanding of the genome goes up and up and up. Obviously, we're going to be referring more patients for testing of germline mutations that we know are pathogenic, such as BRCA1 and 2, such as mismatch repair, etc. So the National Cancer Control Programme, in conjunction with the Children's Hospital Ireland at Crumlin and St. James's, have issued a white paper giving advice on who to refer, why you refer, testing that's done, speed of return, etc. And there is an awful lot of guidelines around the world on the importance of knowing the familial risk in the patient and therefore the genetic risk. And surgeons, obviously this is critical information to surgeons, especially with something like BRCA1, where your surgical approach to the breast, for example, might be radically different if there was no BRCA1 mutation. And even with prostate cancer surgeons, with pancreas surgeons, with gynecologic surgeons, the presence of BRCA2 and other germline mutations can seriously impact on the role of surgery and the extent of surgery and prophylactic surgeries. And also in my world, in BRCA1 mutated breast cancer and in BRCA mutated prostate cancer, drugs have been synthesized now exploiting the Achilles heel of the cancer, which is the oncogenic addiction to the PARP enzyme. If you have a mutated BRCA enzymes, the cell becomes dependent on PARP to repair DNA damage, which happens in normal life. So if you can inhibit PARP with oral PARP inhibitors, you can have a very beneficial effect on cancers that already have BRAF or BRCA mutations. So this is an example on how surgery and medical oncology are affected by cancer genetics. And the field is moving on and on quickly now. You can get saliva kits done from companies such as this one, Color Genetics, and patients can swab themselves at home and send in the kit to Color Genetics and get the results back. So there's an awful lot of danger in this strategy, direct-to-consumer testing. And this is why there's a great onus on our system and many other healthcare systems to have a proper, well-funded and well-run cancer genetics service in order to govern issues like this. So where is cancer genetics, germline genetics in Ireland in 2021? Well, I think there has been some progress. The NCCP have certainly been supportive. Funding obviously is limited. Funding is going elsewhere now. And the service, as you can see from the numbers that I showed in 2019, is operating pretty much at max capacity. And our knowledge of cancer genetics has improved exponentially, but the infrastructure hasn't, specifically with familial testing. So access really needs to improve, it really does. And direct ordering will probably become more and more common, but there are inherent risks with this, and there really needs to be a genetic service that governs this. And obviously laboratories in Ireland that can look at doing mutational testing in the germline are urgently needed rather than shipping everything we have overseas. So thank you very much for your attention. I'll take any questions.
Derrick, thank you for, as usual, an amazing talk. Absolutely fantastic talk. In the interest of time, it's 7:10, so I think from my point of view, I might hand back to the President, and I suppose thank him very graciously for allowing us to host this webinar this evening and giving you a little flavour in a number of different areas of what we're trying to achieve down here as part of a national strategy. So, President, I'll hand back to you and thank you.
Thank you, Paul, and thank you to all our speakers. Just one question came in, Derrick, there on the chat, and I think it's something that all of us as surgeons dealing with cancer want the answer to. Is there any way of predicting who's going to benefit from neoadjuvant therapy? And I'm particularly thinking of the morbidity of neoadjuvant chemoradiation in rectal cancer, where at least 40% of people don't get any benefit. So where are we at with that?
Yeah, that's a very good question. So I alluded to this a little bit in melanoma about interferon gamma signatures and mutational load, seeing who would benefit from immunotherapy prior to any surgery in the neoadjuvant approach. So, you know, moves are afoot in rectal cancer. As you say, a lot of patients won't benefit from the neoadjuvant approach. And why is that? And who are those patients? So I think the answer to this lies in next generation sequencing, trying to predict what's a bad genetic tumour. Possibly the answer to this as well might lie in the microbiome. I think the microbiome has a huge role to play in the genesis of colorectal cancer, and there's clearly good signatures and bad signatures. So I think that's the advantage of the neoadjuvant approach, is that you can gather this information in the context of trials and then you can exploit it subsequently. To me, the best outcomes with cancer, obviously surgery is the definitive intervention, but if you can make surgery more successful with a very targeted, focused and well researched neoadjuvant approach, I think our patients will do much better. I mean, a great example of this is pancreas cancer. We urgently need better treatments for pancreas cancer. Surgery really, the long-term benefit is very small. The systemic, the benefit from chemotherapy and targeted therapy so far in pancreas is very small. So that's one disease that really needs developments. But I think the answer is going to be in the genetics, next generation sequencing for rectal cancer.
Well, thank you, Derrick. And just on that theme, Tom Walsh from Bahrain has just texted in, everything you presented says cancer is a medical disease. Tom, I wouldn't be as fatalistic as that. I think we still have a role. But Derrick, thank you. Yasser, thank you. Zeshan, thank you very much. Thank you to all who have joined us, and thank you particularly to Catherine Jordan and Janelle Sherlock, who are in the Fellows and Members Office. And I hope you feel that the college is reaching out to our fellows and members across the country and across the extended network that we have and providing useful updates for you. We'll be back in 2 weeks' time. I look forward to that. And thank you all for your kind attention this evening.